This was controversies. Oops, that's the wrong one. And I have no disclosure. And I do want to say that was an excellent talk. That's a problem that diabetics, vasculopaths, and ankle fractures are frustrating and very difficult. And that was a terrific discussion. So syndesmotic injuries, we see them fairly often. It's a couple sports examples in the pictures, but motor vehicle accidents or even twisting falls while you walk. And what are the controversies? Do you use screws, suture buttons? Are there some other techniques? Some aspects of aftercare all can be controversial. And the syndesmosis, just for a reminder, is a complex of ligaments that's connection between the distal fibula and tibia. I always warn the residents to be careful with their acronyms, and it's AITF, the posterior inferior tibiofibular ligament, the transverse ligament, and then the distal aspect of the interosseous membrane. And these are all injured with typically rotational forces, but also occasionally some straight or pure abduction forces. And you see these in your ankle fracture patterns, the Log-Hansen's SER4s classically, but also some of the pronation injuries, PERs, and the abduction injuries that do transmit forces across the syndesmosis, up the fibula or up the leg. And then in the Weber C's, of course, we worry about it, and then in some of the Weber B's. And, you know, the mortise instability is the issue. If you injure the syndesmosis, there's displacement of the talus out of the mortise, as seen by a couple of radiographic hallmarks, a wide medial clear space, or loss of tibiofibular overlap. The classic teaching is that the tibia and the fibula should overlap on every X-ray image. And in my own practice, I've seen this, what I thought was a normal syndesmosis. They're close but not overlapping. So I questioned that myself, but you kind of put this all together. And if you see widening of these on any X-ray, you have syndesmotic instability. If you don't see it, but you suspect it because of the injury pattern, then you can do things like stress X-rays, which are the hanging the weights off the foot, or grabbing the ankle and holding it for an X-ray, a stress view, or in my practice, I'll do standing or best effort weight-bearing views. So get them to stand up on that ankle and see if it moves when they can tolerate it, and even repeat it a week after injury if they're not really able to tolerate it when they first come. So some controversies, as I was charged with, regarding syndesmotic injuries is it necessary to remove your fixation at some point? You know, the screws that we fix them with can break. You can get some complications. Is a suture button a good option? That may be controversial. The suture button has some advantages where you can still allow some motion at that connection between the tibia and the fibula while keeping it stabilized. Another controversy will be, I'll try to show you that is it controversial to even fix it when it's unstable? And then finally, and this has been in the last 10 years, the increasing recognition of malreductions and related complications, how you can evaluate for that and what we need to do. There are some controversies there. So I had a discussion with a chief resident probably 8 years ago now, sort of threw away, give me 10 different ways we can fix the syndesmosis. I picked the number 10 out of the air. And then when you go through the different varieties, you can come up with quite a few. You can do a single screw, 3/5, 2 screws. You can do a larger screw, a 4/5. You can do 3/4 Cs. The lateral fibular, medial fibular, lateral tibial cortex are 3, and then you can go through the 4th or medial tibial cortex. You can use a suture button. You can use a screw and wire, where you put screws in the tibia and the fibula and a little figure of 8 wire between the two. Absorbable screws have fallen out of favor, but were available, where you put a screw in, it held it, and then it absorbed so that you were not rigid across there and you didn't see it as much on X-ray. A direct repair, you can suture the ligaments. You can use suture anchors. It's a little bit more new technique that I'll show some pictures of, and you can do soft tissue grafts. You can allograft tendons, all can be done. I don't think the list ends there either. Evaluation of the syndesmosis, the classic cotton test. I think most of the fourth-year medical students should know this when you ask them in the OR. There are ways to do it, but you're stressing directly the ankle mortise, the syndesmosis, and intraoperative is what we're talking about. And there was a nice technique article in the early 2000s from Mark Mizell, the classic, you grab it and yank on it. You can do, you pull it or evert the hind foot to try and stress it open. Problem I have sometimes with the grab and pull is that to hold the leg under the x-ray, you're reducing it to hold it there. So you're reducing it and you're trying to destabilize it. It can be a little tricky sometimes, especially when you're teaching it. And then the technique tip was if you put a lever, a freer elevator or something between the fibula and the tibia and push open, you lever the fibula away from the tibia. It's biomechanically the strongest way to assess if there's a stability there, and it's fairly easy to do. Now, often we'll do all three. There's a recent article just published this year from Greg Guyton's group that showed arthroscopic evaluation of the syndesmosis. And arthroscopic evaluation of ankle injuries, ankle fractures is becoming more commonplace. And they wanted to see what it looked like when the ankle mortise was unstable arthroscopically and was a reliable indicator. And they had their specialized probes. It's not the typical probe, but the idea is there. It's a sphere. They had a 2 millimeter sphere that they would put between the tibia and the fibula, and then they did a 3 millimeter sphere. And the 2 millimeters, it was sometimes unstable. If you could fit a 3 millimeter probe between the fibula and the tibia, it was definitely unstable. So that was an indication of separation of the fibula from the tibia to a distance of 3 millimeters that they showed correlated with syndesmotic injury. And that is their probe. It doesn't show the sphere, but it shows it up arthroscopically in there, and that's a great view of an ankle, by the way. So assessment of your reduction intraoperatively, you want to be careful about several things. You really need to see a good AP, good mortise with things lined up, and then also really critically an excellent lateral. You need to get the talar dome on FOSS. You need to see both the medial and lateral cortex of the talar dome superimposed and that great joint line view. And in that view, the middle top, the fibula should be the middle half to posterior half to posterior third. It can't be too anterior, it can't be too posterior, and that's a ballpark. And then also, if you're assessing it and then you're fixing it, you check it both times, because after you put the screws in, it can change. And this brings us to the next point. When we're looking at that reduction, we have started to notice that we're getting it wrong sometimes, and it was seemingly a little unexpected. Group in New York began getting routine CT scans postoperatively just a few days after surgery. And of course, you see the syndesmosis right there. And what was happening is they were noticing that the fibula was not quite sitting right in the groove of the incisura, and they were surprised by this because they were pretty sure when they left the OR that it was in the right spot. And why would this occur? Well, the incisura it's a curve. So you have the fibula, the convex fibula fitting in the concave incisura, and if it's a little flat, it might rotate out of there. And there's a nice study that showed that the shallow incisura anatomy, you're a little bit more prone to an anterior malreduction, comes out the front. And even for the deep ones, a nice deep groove that the fibula should seemingly sit in there fairly well, you can get posterior malreductions or malrotations especially. And these are me playing with the anatomy 3D, but the top-down view on the right shows, an idea that can be fairly flat. And I love the drawings they put in the books. They're always sort of a nice big deep groove that shows you all the lines, but it's never that way in real life. So, and what we're doing to reduce the syndesmosis can also affect this. So, you take that nice big tenaculum clamp, you squeeze between the two bones, or orthopedists would like to do things, click it another time, make sure it's nice and tight. But if you have the clamp a little anterior, and you're really exerting a lot of force between those, so the metal clamp or the screw especially, the bone is going to go where that clamp and that screw you direct them to. So if the clamp's a little anterior, you can anterior malreduce. Extreme example would be that radiographic CT scan down below, which shows the screw aiming quite anterior, and it does pull the fibula forward. And there's an article showing the risks for that problem. So there's a series of discussions in the literature about syndesmotic malreduction and what we can do about this. You can look at it directly It's a little bit more dissection, but you get a look and a feel over the anterior syndesmosis to have a sense that you're not bringing it forward or malreducing it. There are some 3D fluoro imaging systems available where you would get that view before you left the OR and then change it. Some ways that you're more exacting with your fluoroscopic technique that you can assure your reduction. That's a nice paper with Tornad and Ostrom. And then the Churchsea test is they took a little dye and injected it, and we're able to see from where the dye went a risk for malreduction. They're all ways you can improve theoretically your syndesmosis reduction. So I've just spent several minutes talking about malreduction and the problem, and indeed there's some question that it's not that bad. That same group from New York that sort of pointed it out to us kept looking at it, and in some of the ones where they identified malrotation or malreduction in the syndesmosis, patients didn't do so bad. Their functional outcomes were not too terrible, so they stopped rushing in to change these when they found them so often. Significant malreductions are bad, but mild malreductions are probably not too bad, and even can be affected by a couple things I'll show in a minute. So this idea of the rigid screw, the rigid clamp being a problem, suture buttons are fairly commonplace now. It's essentially a way to compress or squeeze between the fibula and tibia, give the soft tissues time to heal the ligaments, and the buttons are outside the bone, the suture holds between those two. And Chris Coetzee from Minnesota published on this in 2008. And the idea is that you can maintain reduction, avoid that widening of the syndesmosis or the mortise, and still have actually a little bit of motion, which is physiologic. The fibula does piston up and down 2 to 5 millimeters, does externally rotate as you move your ankle, and there's a little bit of anterior-posterior translation as well. All these are physiologic motions, which the suture button could allow, where the screw, of course, would not. It's not rigid. Some theory that it can even aid the reduction. If you take 2 suture buttons, if you put one in and then a second one slightly out of plane, they will compress and encourage that round bone to fit into the round groove a little bit more. And of course, since they're sutures, you don't need to remove them. But suture buttons developed some concerns with usage. There was some reports of loss of fixation. They had progressive x-rays over time that showed what they termed as creep, or a little bit of loss of, a little bit of separation between the buttons. You can put a ruler on the buttons over time and see that it can widen a little bit, which would be a worry. The knots caused some irritation. I had about 5 that caused a wound dehiscence in my own ankles. That can lead to infection. There's a situation of a possible painful aseptic osteolysis that was shown, and then a suture button can cost hundreds of dollars, where a screw should be about 10% of that. So they're more expensive. But when you factor in cost, there are a bunch of articles about the cost of syndesmotic fixation, which favor the suture button, even though it costs more, because they all factored in screw removal, which is another surgery for that. Another suture button concern is they don't control rotation. And there are some potential malrotations of the fibula that can occur, that failing to control them with the suture button can be an issue. So back to screws again. If they're in there, do we need to take them out? This is a controversy, a big one. It's been for years. Some people always take their screws out. Some people never take their screws out. Some people do it occasionally. Why take them out? They can break. They don't all break, but with that motion I described, the screws can fatigue and break. They'll break in the tibial. They'll break in the space. Screw head will pop off unusually. You can certainly get some loosening or lucency around the screw, which is a little funky on x-ray. And I think they can lead to pain for the patient. So there is literature about this. It's an x-ray complication. You take them out if you're concerned about x-ray complications where you are or for your patient. But indeed, in the literature on it, it's pretty convincing that there's really no functional difference whether you take the screw out or leave it in, a syndesmotic screw. And this is over several studies and even some prospective randomized designed trials. There's an interesting study that shows, and they randomized this, where they had screws left in that were broken, so screws left in that remained intact, screws left in that were broken, and then ankles where they took the screws out. And the best group was the ankles where they broke. So, it restored a little bit of motion syndesmosis. It's not entirely clear, but it is clearly controversial that screw removal is necessary. They certainly can stay. And indeed, if there is a malreduction in the syndesmosis that you've identified and you've got a screw across it, if you take that screw out, it can spontaneously reduce. And this was shown, again, by that group in New York or something like that, where they had identified malreductions. When they removed the screw, they got another CT scan, and the malreduction had improved or reduced. So a little bit of new technique. There are suture anchor devices available now where you have an anchor and then a non-absorbable suture or Merceline tape that connects between the two anchors. So the idea, you'd put one at the fibula, put one at the tibia, tighten the anchor down, and if you do one in the front and one in the back, then you can actually establish a little rotational control. And these are out on the market and available for discussion. Is yet another way to think about doing this. There's some literature as well. So describing controversies about the syndesmosis, it's probably a rock of Gibraltar that if it is unstable, we need to fix it, right? I mean, that's clearly, we talked about this, if the cotton test is positive, it's got to be fixed. That's a rock of Gibraltar. You need to fix it when it's unstable. So this is a neat study, one of the studies you can probably only do in the Norse Peninsula. I think this is Norway or Sweden. They prospectively randomized patients who had intraoperative instability of the syndesmosis, a positive cotton test. 11 of them got no treatment, no screw, no treatment for the syndesmotic instability, 13 got a screw. And at follow-up, at 2 years, there was no difference in their outcomes. Functional, no pain difference, no difference in arthritis. They did MRIs on all of them and showed no chondral issues. So here was unstable syndesmosis shown in the operating room, no treatments, and no difference. So I guess the Rock of Gibraltar has fallen. Anyway, so there's a lot of controversy. There is really no consensus, but I think you try to, another indication to me personally of no consensus is when you see a mixed media. So you see a suture button plus a screw, because the screw then sort of obviates the advantage of the buttons altogether once you put that in. But so what do you do when there's all this controversy? I think you try to establish in your own mind best practice or good practice. If it is unstable, it should have stability assured. You want to do your best to avoid malreduction. If you are worried about it, assess it, including a post-op CT scan. And if it has occurred and there's issues with it, removal of the hardware in that circumstance and malreduction is important. Take your hardware out as needed. So if they hurt from the screw, if there's some issue with the screw, you can take it out, but otherwise you can leave it in. And suture buttons do work well with considerations. Thanks.